Hello and welcome to Health Live at Seniors Today. We are delighted to have you with us. And with us today is leading ENT surgeon, or let me get the name right, otorhinolaryngologist, Dr. Ajay Doiphode. And he is going to be speaking with us on ENT care for senior citizens. A little about Dr. Doiphode. He is a senior and well-known ENT surgeon practicing for over 20 years. He is with the Nanavati Max Super Speciality Hospital and has performed more than 5,000 successful ENT surgeries till date. He did his MS ENT and Masters from the KEM Hospital, which is the GS Medical College. He has a fellowship in Functional Endoscopic Sinus from Austria and a fellowship in Cochlear implant and implantable hearing aids from Germany. Dr. Doiphode is currently president of the Mumbai ENT Association. He's also Honorary Head of Unit at the HBT Municipal Hospital, which is attached to the Cooper Hospital in northwest Mumbai. He has 2 private clinics in Vile Parle and Andheri in Mumbai, and his special interests are endoscopic nose, sinus, and skull-based surgeries, and endoscopic ear surgeries and thyroid gland surgeries. So without any further ado, I would welcome Dr. Ajay Doiphode to Health Live at Seniors Today. Welcome, sir.
At the outset, let me thank Pradhimanji for inviting me and having over for this session. And without any delay, I will start the session. So,
yes. Over to you. And you have a presentation for our readers today.
Right. So I have a very brief presentation to set the ball rolling. So let me share my screen.
Yeah. And until Dr. Doiphode shares his screen, those of you who have any questions, please put them in the Q&A tab and ideally mention your age and your gender, as it will help Dr. Doiphode answer your question better. Over to you, Doctor.
Yeah. So can you share my, can you see my screen now?
No, we can't. We just...
Let me try one more time.
Try now, sir.
Can you see it now?
No, we can't.
1 second.
Yes. We've started now. Okay.
Is it started now?
Yes, it has.
Okay, great. So, okay, fine.
Yeah, that's right.
So, hearing is one of our 5 senses which starts dwindling down with age. And this is the second most common cause of years lived with disability. Unlike blindness, deafness, one can't see and often gets ridiculed, unlike the blind who get sympathized. So this happens at the inner ear level. This is the external ear, this is the eardrum, this is the middle ear where the hearing bones vibrate, and this sound gets conducted to the cochlea. This is the snail-shaped structure, and from here through the nerve to the brain. So the weakness starts in this part of the inner ear, where the disease can be either in the cochlea or the hearing nerve, or at the higher level, which is at the brain, that is the brainstem or the cerebral cortex. So if you do a hearing assessment or a hearing testing or a audiometry of a patient a senior citizen who has hearing issues, we get this typical kind of an audiogram. This is not a very complicated graph. This is a very easy graph to understand. On x-axis, we have the various frequencies, sound frequencies, and on the y-axis, we have the decibels from 0 to 120. So the more the values, the proportionally the deterioration is more. So these are the low frequencies, these are the mid frequency, and these are the high frequency. In a characteristic audiogram of a senile deafness patient, the high frequency starts going down first. They can still manage with hearing without any conversational issues. Once the lower frequencies and the mid frequency starts going down, that's when the patient starts complaining he can't hear or has to keep the TV volume high, or is unable to hear clearly in a noisy room where 2-3 people are talking. Or sometimes now with the new thing which we have seen is with COVID is people are wearing masks, and because of masks, they are not unable to lip reading. Our brain is a very smart organ. It tries to overcome the hearing handicap by allowing us to lip read. But when people are outdoors and they are surrounded by people wearing masks, they are unable to lip read, and the hearing deterioration is more pronounced then. So senile deafness is a natural physiological process, like how we develop cataract in the eyes. It's not a pathology, it's just an opacification of the lens. Similarly, senile deafness, most of us will have it or already have it. So it starts by age 60, and typically it starts in 1 year and usually involves both ears. There are other causes of senile deafness related hearing loss, which we call as nerve deafnesses. And there are certain important conditions which just I thought I should brief you on that. There's this condition called as sudden sensory neural hearing loss, which is nothing like a stroke of the inner ear hearing nerve. Here, typically one fine day you get up and you can't hear things. And there might be some dizziness associated, or there might be some nausea, vomiting. Also, the patients will come when he keeps that history of sudden loss of hearing in one of the ears. And once we do an audiogram, we typically see the graph, which is, showing only hearing loss, which is significant, sometimes very profound in one of the ears. And this is an emergency medical condition. If treated in the first 48 to 70 hours, the hearing recovery is near normal. But if there is delay, or if the treatment is not started on time, then it can lead to permanent hearing disability. Now, in a metropolitan city like Mumbai, we are continuously bombarded with loud noises. Maybe for a brief second, which might be a gunshot or an air honking from the traffic noises, or continuously music, or sound, which is, the ears are bearing the brunt. So these are very detrimental to hearing. So what we see is that this is another cause of nerve deafness in practice. And another important cause in senior citizens is they are on multiple drugs. So certain drugs are ototoxic. That means they can cause weakness or degeneration of the hearing nerves. So common drugs which are likely to cause hearing loss are antibiotics, certain anti-cancer drugs, certain non-steroidal anti-inflammatory drugs, and sometimes we have seen even infections like malaria, where we give quinine and chloroquine, have also caused hearing. So it's very important when you notice any hearing-related symptoms, whether it is diminished hearing or any fullness in the ear, any buzzing, ringing, or any vertigo, especially in treatment for some chronic illness like tuberculosis or cancer. It is important to notify your treating doctor that these are the new symptoms we have noticed. He might stop the drug for a brief period, get the hearing assessment done, and if it's confirmed it is ototoxicity, then either the drug might be substituted, or it can be, you can take a drug holiday for a few days as advised by your physician. There are other important causes also, which are structural defects or which are anatomical problems in the ear. Like this is an image of a eardrum. And we can see there is a large perforation or a hole in this eardrum, so much so that the hearing bones are exposed. So this is one of the hearing bones, malleus. This is the hearing bone second incus, and this is the stapes bone. And we can see the middle ear through the perforation. It's a pretty large defect, and sound is not going to get conducted into the ear. And this patient with age will have a mixed kind of a deafness where the nerve is also affected and there is a conductive problem also. Similarly, there is a bone-eating disease called as cholesteatoma. It's not a cancer. It's a non-malignant disease. But again, here you see there is a defect in the eardrum and also the bone is involved. So this kind of issues also, unless and until you visit a ENT surgeon, he would examine and confirm what is the exact nature of your hearing problem. Now, assessment of hearing is very simple. We do certain objective or subjective tests, and we determine the nature, the quality, the quantity of hearing loss. So the commonest test which we use is called as a pure tone audiometry, which I'll talk about in a while. Second is a tympanometry, which gives us a status about the middle ear, what exactly happening, whether the hearing bones are fixed, whether the middle ear pressure is normal, the eustachian tube, the tube which connects the nose and the ear is functioning normal. And in kids who can't participate in the hearing test, then we use a subjective test, which is objective test, where the graphs and the values are determined by attaching a probe like this inside the ear. And this is what we call as the ECG of the ear, or the auditory brainstem response, which is one of the most accurate hearing assessment results. A little elaborate than the pure tone audiometry, but in certain situations, we require this auditory brainstem response testing also. So a typical hearing test or an audiometry is about a 5-minute test, which is done by an audiologist with an audiometer. Ideal setting will be a soundproof room with a 2-door setting, with a transparent glass in between, where the patient is wearing a headphone. Sound stimulus is given by the audiologist through this audiometer. She has a speaker to communicate. So the responses are given by the patient, and proportionately a graph is plotted. I showed an audiogram initially, how a typical audiogram, x-axis and y-axis. And depending upon what the interpretation is, we come to know about the hearing issue. So most commonest problem what we find in senior citizens is senile deafness, and according to WHO, 80% of all deafnesses is avoidable, out of which 50% are preventable and 30% are treatable. Now, evolution of hearing aids, I would say it's like, you know, how music devices have, you know, kind of transformed over centuries. Like initially there were gramophones, then we had loudspeakers, transistors, tape recorders, CDs, Blu-rays, CDs. Similarly, the hearing aids which were initially worn were body level, the ones which were like transistor with a wire hanging out and things like that. Now we have this most sophisticated and refined hearing aids which are almost invisible, or this smaller Bluetooth-like devices which women can hide under their hair and things like that. And they have variety of features. They are there is Bluetooth connectivity. They can be connected to the mobile, to the TV, and they have features such as, you know, they can sense the surrounding ambient sound, and the internal settings get changed so that the unwanted sounds don't enter, and only the conversational or the voices which are required for hearing are transmitted inside the ear. So the common question asked is, which one is better? So which hearing aid? So it's like, you know, asking any electronic gadget, something like a smart TV, which one is better? There are different brands in the market and all serve the same purpose. So as long as you are satisfied with one of the brands and, you know, you've done a research about it, or it's comfortable on your pocket, you should go for that. But if you ask me, one size doesn't fit all. And when we decide about a hearing aid, there are certain criteria which we have to keep in mind. the most important is the degree of hearing loss. So a lot of times patient will come and say, doctor, can you give a cheaper hearing aid? So it's not about the cost, it's about how much amplification is required to correct your hearing handicap. So that proportionately you will be recommended a certain model and a make. Then communication needs. A housewife and a CEO of a company, the needs are different. So obviously, you don't have to go for a very high-end hearing aid if you are homebound and things like that. Age does matter. So higher the deterioration, higher will be the hearing loss, and accordingly, you might require a strong class hearing aid. Then individual choices. As I said, somebody might prefer an iPhone, somebody might be happy with an Android base also. So similarly, once you are given a multiple option, you are the best judge to select your hearing aid. Now, what we see in practice is there is a lot of inertia and reluctance to wear hearing aids. And the biggest reluctance is, the social stigma, especially in women, who even after 60 plus think, no, the person surrounding them or the family members may think, she is deaf. But this taboo I have seen only in Indian scenario. When I went to Germany and I was doing a fellowship, I used to see people wearing big cochlear implants, the speech processor or outside, and nobody used to battle an eyelid. I think it's more to do with our culture and things like that. I think a mindset change is required here, where we don't look upon patients with hearing aids or cochlear implant devices. So in Western countries, they don't give a second look, even if you're wearing a hearing device or things like that. So the taboo is definitely there associated with hearing aid. Resistance, like being in a state of denial. I can hear. See, what we are saying here is you are not tone deaf. The sounds are reaching the ear, but the discrimination problem is there. So definitely that is not we call as, good hearing or something. So you will require aid to overcome your hearing handicap. And there are misconceptions about hearing aid, like mere nana ke chacha ne hearing aid यूज किया था और वो साउंड हियर नहीं कर पाते, बहुत लाउड साउंड्स जाती है. Yes, this was the initial problem with hearing aids when people were using analog hearing aids. Analog hearing aids used to amplify all the sounds. So if I'm sitting in a quiet room, so I would not get the ambient sounds also inside the ear. But with the analog hearing aid, if you go in a noisy environment, you go on a road or you are in a crowded room, so all the sounds get amplified, and obviously you are not able to hear what you're supposed to hear, and patients would stop using hearing aids. So this problem has been overcome by digital hearing aids, programmable hearing aids, where selectively we can program the hearing aids according to your hearing requirements, so that the unwanted sounds are filtered and the pleasure of hearing is restored. The most important factor which I feel is they are costly, they are not indigenous, these come from Europe or US, and there is a certain price attached to it, and they are not covered in insurance. So a lot of senior citizens who are probably dependent upon their kids or on their pension, they are not able to afford this kind of hearing aids. But there are certain issues. If you have a hearing loss which requires a hearing aid and you are not wearing, then you can land up with certain problem. So that the hearing aids keep the nerve firing. So if you're not wearing the hearing aids, the hearing deterioration will continue to happen. So if you do serial audiograms and see, and if you're not wearing a hearing aid, it definitely shows a 5-10 decibel hearing loss over a period of years. So which is not a good thing. Second, obviously it gives you hearing and gets back to the social stream. Otherwise, patients who are not hearing, they kind of cut off themselves from a crowd or from social gatherings, thinking that they might be ridiculed or, they might be the laughing stock. So a sense of negativity, and these patients tends to get a little depressed. So that can be avoided when you start accepting and wearing a hearing aids. It is now, we have enough scientific medical evidence that patients who don't wear hearing aids, they are higher function, cognition, thinking, memory, all those are affected. They are more susceptible for certain problems because the nerve is not firing. That part of the brain where the sound is supposed to go, it becomes a little inactive. And if this inactivity spreads to the other parts of the brain, then you are at a risk for Alzheimer's and dementia. So the risk of dementia is 5 times if you're not wearing your hearing aid. So I would conclude this part about senile deafness by saying that blindness separates us from things, but deafness separates us from people. And this quote is from none other than Helen Keller, who was not only deaf, but she was also blind. And once she was asked if God was kind enough to give you one sense back, then what would you have? And she said, I would like to have my hearing back. Now, tinnitus is another symptom which affects senior citizens, and this can be either a whistling or a ringing, humming, buzzing kind of noise, differently described by different type of patient. Now, the most important thing to understand here is, again, it's a symptom, it's not a disease. So underlying pathology or cause needs to be investigated. One of the most important cause of tinnitus is senile deafness. So again, resistance to wearing a hearing aid, your deterioration of hearing nerve will continue. And so much so to a level where you will start getting tinnitus. And this is a very disabling symptom because we don't have any permanent treatment, or it's reversible. And this will definitely affect you so much so that your sleep can get disturbed. We've had patients in medical literature who have also committed suicide because of disabling tinnitus. So you should not reach a stage where you are resisting a hearing aid and reach a level where tinnitus starts developing, because as I said, we don't have any definitive medical management for this condition or a surgical treatment for this condition. The third most common problem related to ears is vertigo. So as we know, our ears, they not only help us hear, but they also help us to maintain balance. The inner ear has the balance sense organ. So balance is basically dependent upon our brain, our eyes, our inner ear balance system, and our joint and muscle sensations, which continuously are going from the left and right side towards the brain. When there is harmony, when there is symmetry, we don't experience any dizziness, any swaying, any wobbly sensation, and we maintain our posture. But if you start getting a spinning sensation of your own self or your surrounding, which is an illusion, this happens because of the balance system or vestibular system. And this is a very common problem which we see in elderly population. And this is again mostly because of aging of the vestibular system, but there might be other causes which can be also causing this vertigo. Again, vertigo is a symptom, it's not a disease. I know a lot of patients who come to me with, pride saying we have been diagnosed vertigo by our family physician. So I am like, okay, and the vertigo is because of, and they don't have an answer. And I've had patients who have been taking vertigo medications for 3 months, 6 months. The oldest, I have had a patient who has taken the same drug for 2 years, and so much so that anxiety psychosis has developed, and he's not ready to let go of the medicine. That he says, no, if I don't take the medicine, I feel I'll be very dizzy, uncomfortable, and things like that. So an ENT specialist is the one who you should be going first, because it's a gray area. So sometimes you don't know whether to go to a neurologist, an orthopedic surgeon, or a physician who would be treating a vertigo. But out of 10 times, 7 to 8 times your vertigo is related to your ears, your inner ear, your vestibular system, and an ENT person should be the first person you should go and consult. Now, there are certain issues which are related to nose, and the commonest which we see is nosebleeds or epistaxis. Now, a lot of senior citizens are hypertension patients, blood pressure patients. They are cardiac patients. They are on antiplatelet drugs or what we call as blood thinners, ecosprin or clopidogrel or warfarin and things like that. So if you have a sudden rise in blood pressure, you will start having spontaneous bleeding from the nose. The minute you see the sight of blood, your blood pressure shoots up, and it's like a vicious cycle. More the blood pressure, more the bleeding, more the panic, again the blood pressure going up. So I would advise, whenever there is nose bleeding, first of all, stay calm. Try to pinch your nostril and give pressure on the bleeding portion. You might have to tilt a little forward with your mouth open so that the blood doesn't go into the throat and you are able to spit it out. Ice can be applied. If you have a blood pressure measuring device at home, check your blood pressure. If the blood pressure has shot up excessively, then it needs to be got under control immediately. So home remedies would be pinching and pressurizing the bleeding point, applying ice. If still the bleeding is not stopping and there is excessive bleeding, then I would advise to push in a nice clean cloth in the bleeding nostril till the time you reach a close by nursing home or an hospital where you can seek immediate intervention. So the blood thinners don't help to clot the blood, and then the bleeding is more and more panic sets in. So my advice would be to stay calm, keep your pressure under control, don't miss your tablets. And winter and summer is the time when the nasal mucosa or the nasal lining dries up and is crusting. Don't disturb the crust. Use moisturizing lotion of their own, and you don't create raw areas which will trigger this bleeding. Another problem related to nose indirectly is what we call as epiphora or eyes. Now I'm saying is nose because the lacrimal system starts with the lacrimal gland, which produces tears which go along the surface of the cornea, keeping the cornea moistened, and then enters this tiny opening called as the punctum, and these channels, which are called canaliculi, at the upper and the lower portion of the upper and the lower eyelid. And then it goes to a sac or the tear sac and gets drained inside the nose. So this is how the indirect connection is there related to nose. So this happens usually because there is blockage. It's basically a choking and a plumbing issue. So there is a drainage issue of the tears. These tears are going into the nose and into the throat. And it's a very insensible thing. But if there is blockage, then it gives excessive watering of the eyes and causes blurring of your vision. And most of the patients who require cataract surgery, the eye surgeon is not ready to operate the eye unless this issue is sorted. So this issue can be sorted by an eye surgeon or an ENT. Eye surgeon will do externally, giving a scar on the face, but an endoscopic ENT surgeon will go through inside the nostril and open up this drainage points so that even if any of this passage is blocked, the tear drainage is restored. And finally, coming to throat-related issue, the common issue which we see in senior citizen is what we call as acid reflux, laryngopharyngeal reflux, LPR, or also called as throat acidity. So here we see a endoscopic picture of the throat. This is the base of the tongue. These are the vocal cords. This is the trachea or the windpipe. And this is the region where the food enters into our stomach. And what we here typically see is reddishness of this portion in front of the food pipe opening. And this is classical of what we call as laryngopharyngeal reflux. Now, our stomach lining and our food pipe lining can bear the brunt of acid, digestive acid and enzymes and juices. But due to some reason, if this acid or the digestive juices come into the throat, it is not able to handle this chemical pH. And in that response, it produces mucus. And patients of typical of acid reflux will say if they have a sensation something is stuck in the throat and they have to keep on constantly clearing the cough, and they feel as if the throat is always choked up. So this is a very common issue, and all you need to do is a small endoscopy by an ENT surgeon. This is an endoscopy, a real-time endoscopy. I will just play this video. Here we see a patient who's sitting in front of me. I'm holding his tongue and the endoscopic is going parallel to the tongue. And you can see the vocal cords and then this reddish areas and this typical granular or irregular areas, which is characteristic of the acid coming up in the throat. So this scopy doesn't take up even a minute, but it confirms the diagnosis. It also rules out other problems, tumors or any vocal cord paralysis or any neurological issues which might be causing this issue. So this is a very common problem, acid reflux or laryngopharyngeal reflux. And needless to say, snoring. This is ghar ghar ki kahani. Typical, the spouses think if there was a silencer, they could fit on their spouse's nose or throat. So some go to an extreme lengths also, and there has been, in Western world, there have been divorces because of snoring of the partner. So what happens in snoring is the airway, the passage, when we start breathing from the nose, it's supposed to remain open even during sleep. But during sleep, this passage, which is more like a muscular tube, it loses its tone and it collapses. And in addition to that, if you have any obstruction in this breathing passage, right from the level of the nose to the throat, so whether you have a deviated nasal septum, that is the partition which separates the nostril is crooked or blocking one of the nostrils. You have hypertrophic turbinates. These are sausage-like portions inside the nose. Because of allergy, they are swollen up. Or adenoids, which are very common in children. Even children snore, so which is obstructing your breathing. Then you have this obstructive sleep apnea, where your breathing stops for a few seconds. Even in a normal 7-8 hours sleep, we have this few millisecond, brief millisecond pauses where breathing completely stops. But if you don't have a pathological apnea, then the breathing is restored. But if you have a pathological problem, like an obstruction, or if the brain is not able to send signals to keep this passage open, what we call as central apnea, then you will land up with certain problems. And the commonest problems what we see about obstructive sleep apnea is daytime drowsiness. Like the body is supposed to inhale carbon dioxide and expel CO2, but because of this blockage, the CO2 is not expelled out, it remains stagnated in the body. And CO2 has a property to put you to sleep, induce narcosis. So these patients will fall at the drop of the hat. Sometimes you're just talking to this person and you suddenly notice that he has fallen asleep. And more dangerous it is when they are on the wheel, when they are driving and they meet with near fatal accidents. This pushes to certain cardiac problems like hypertension, certain heart attacks. Most of us, we hear from, he passed away peacefully in sleep. Probably, if you would have been investigated, probably he might be suffering from obstructive sleep apnea. Those pauses, those brief pauses, probably in its case, got extended for a longer period, and the brain couldn't awaken that person, and he just stopped breathing and he had an heart attack. It makes you more susceptible to certain neurological problems like stroke, memory loss, causes metabolic problems like diabetes. It can push you to depression, insomnia. And as I said, death is a real risk with snoring and sleep apnea patient. Again, we do an endoscopy. This is a real-time endoscopy. This is looking inside the nostril. We see a very hypertrophied passage a crowded nose, hardly any passage to breathe, looking with an endoscope, a flexible endoscope. Now, as I advance the scope, with very difficulty, I can manage to get into this tiny space. And this is the junction of the nose ending and meeting the throat. So it's a very crowded passage, and this patient will have really bad snoring. So unless investigated, this might go unnoticed, and this definitely requires surgical correction. And this is looking at the back of the nose, what we call as nasopharynx. Sometimes there are hypertrophied adenoids here, and we see the vocal cords here and the breathing passage. So we induce the patient to sleep by giving him a sleep medication, and real time we observe his airway, what level is the airway, and then decide a plan and a management for this. Now this can be treated non-surgically by using devices such as BiPAP and CPAP, where nothing but you have to wear this mask, which is connected with a tube, which is connected to this machine. So a sleep study will tell how much pressure is required for inspiration and expiration. Every day, every night, you have to wear this mask, and this prevents your snoring and other risks which are associated with snoring. So not all patients are tolerant to this. They find claustrophobic, or they have anatomical problems. So the pressures are very high. The noise of the machine itself doesn't let them sleep. So those patients may require surgeries then. So in surgeries, we do variety of surgeries depending upon what level the obstruction we have to unclog. So sometimes we have to remove a part of the palate, tongue, what we call as a classical UPPP or a uvulo-pharyngoplasty, where by removing surgically, we have managed to widen the airway or the diameter of the breathing passage. And this is how post-surgery, the tongue looks, the oral cavity looks, where there is no small tongue or the uvula, and the palate is appearing scarred. But what we can see is definitely the space is improved. Sometimes the palate might have to be addressed, where we use a radio frequency to do this channeling. Sometimes we have to make cuts and suture to shrink the palate. So if a palate is looking like this before, where you can't see the uvula or the breathing, the throat, and after surgery here, you can see a glimpse of the throat. So depending upon the diagnosis and the level of obstruction, the treatment is planned. So I would end my presentation and would be happy to take the questions.
Thank you, Dr. Doiphode. Very detailed presentation and session, but we have a problem. I have 30 questions that have come in, or somewhere around that, and there are a few which have come by the mail also. So I'm going to get into the questions soonest. So we have a question from Mr. KV Lakshminarayan, who asks, I have a small growth in my voice box, polyp, I think. With medication, it has not subsided. Is there a way to avoid surgery?
So it is a benign, non-cancerous growth on the vocal cord. Usually it's on single vocal cord, but sometimes it can be bilateral also. The commonest symptom that you will have is hoarseness or huskiness or change of voice. Sometimes it can cause breathlessness also. So there is no medical management for polyps, and it's better that it needs to be operated surgically, and the excised specimen needs to be tested for cancer also. So I would definitely say that there is no medical management, and ideally you should get operated rather than avoid the surgery.
Thank you. We have a question from Mr. Naveen Chandra Shetty, who is male, 72 years. He asks, is there a safe method to remove earwax?
Okay, so this is again a very common issue, and I have posted a video on YouTube. You can go through which addresses the issue, because I probably have to answer this question about 10 times a day. So I have made a video, and for the information of the general public, I have put it. So let's understand wax first. Wax is a natural secretion like sweat. It is secreted in the ear by the wax glands for a purpose. It prevents dryness of the ear canal skin. It is antibacterial. It helps to trap dust, especially when you are in a dusty environment. And it is produced on a daily basis, and it's got a natural auto cleansing mode also. So whatever is produced after its use, it gets excreted also without our knowledge, propelled by our jaw movements. So only people who tend to fidget with this natural process by using earbuds or shoving any foreign objects, they disrupt this process. They push the wax further inside toward the narrowest portion of the ear, causing more ear wax secretion and more wax deposition. Eventually, they will have blockage, pain, hearing issues, and sometimes so much so that they might require attention. So I would say the answer to your question is, A, you don't need to clean your ears regularly. You don't need to put anything inside your ears. What you should do is annually you should get your ears examined. If there is wax, then in a scientific way with special equipment and instruments, a ENT specialist will be able to clean it for you.
Thank you. We have a question from Mr. K.A. Surana, who is age 69. I'm getting cough once I get up in the morning and continue for about 20 minutes. Spit cough, off-white color. It stops after 20 minutes. Some days continuous and some days intermittently. He needs...
Right. So we would need more history on that, but what I would like to know whether he's a smoker or not, because the cough he's describing can be a typical smoker's cough also. So acid reflux won't give you so much cough, and there are other issues which we need to look in also. This can be a simple bronchitis also, which can be causing this kind of cough. So unless we have more history and examine this patient, we'll not be able to give any definitive advice to this patient.
Right, thank you. We have a question from Mr. Chandrakar Velhal, who says, my left ear is very weak to listen since many years. Can you suggest any drops? There are a couple of more questions so his other question was good ear drops for anti-allergic.
So the first part I didn't get. He said his ear is weak.
His left ear is very weak since many years.
Weak means he's unable to hear.
Unable to listen, weak to listen, yeah.
Right, and how old is he?
He is... he hasn't mentioned his age.
Right. So I'm assuming since we are addressing to this senior population, so this might be a age-related hearing issue, what we call as senile deafness. And yes, an accurate assessment will be done by an audiometry testing. And depending upon the hearing loss, if it's mild, probably it might be put in on some supplements. But if there is moderate to severe hearing loss, then as I've already mentioned in my talk, it's better and appropriate that a suitable hearing aid is worn so that not only the deterioration is arrested, but also other issues such as Alzheimer's and dementia are also kept at bay.
Right. Thank you. We have a question from Mr. DJ Santa Maria. Could acid refluxes be the beginning of cancer?
Yes. In the long run, if it's not it's been a very chronic process and it's not treated, yet it can definitely be a risk factor for cancer of the throat also.
Right. We have a question from Mr. Shankar Chauhan, who is 82 years old. He says he has a problem of distance hearing and differentiating between two or more consonants.
Yes. So what happens is once your speech frequencies are affected, speech frequencies are the ones where on an audiogram we have an area which we call a speech banana, where your consonants and your vowels are falling. And if typically the graph shows that your deterioration is beyond the speech banana, then of course, then there is no way medicines or surgery can help you. Then probably you will require a hearing aid if you don't have any pre-existing ear disease or anything.
Right. Thank you. We have a question from Asha Nigam, who asks, what are cyst-like structures on one tonsil?
Yeah, so sometimes you see this yellowish or brownish soft bulges on your tonsils. These are fluid-filled swellings, which are again benign, non-cancerous, most of the time asymptomatic. But just because you have noticed them, then you start observing them more, and then sometimes anxiety sets in, whether any cancer is kind of coming up there. So most of the cysts don't require any intervention, but if they are symptomatic or they are growing in size, affecting your speech or causing you discomfort, pain, or more so if the anxiety levels are high, then the only way would be to eradicate them is a tonsillectomy surgery. But as I said, most of them are harmless, benign. If you just do an annual checkup and keep a tab on them, you won't require any active intervention for them.
Right. Thank you. We have, very many questions that have come in. I'm just taking some representative questions, and then we'll take on the others. We have a couple of questions on earphones. One is by Rajesh Verma, who says, can I use earphones if I have moderately severe hearing loss? He is 70. There's another question from someone who's an anonymous attendee who asks, is it okay to use earphones like the ones we use for mobile phones, or is it harmful, especially the Bluetooth variety? And there's a third question, which is also there from Naveen Chandra Shetty, who asks, which is better, wired headphone or wireless?
Right. So all these are probably, related to wearing hearing devices, the headsets or the earpods, whether wired one is better or wireless is better. So the concern here is whether using excessively the mobile phone or being on the phone continuously affect your hearing or no. So what we advocate is a simple 60-60 rule. When you have to attend, say, long meetings, or when children have to attend online classes. So if you have to hear with a hearing device in your ear, so a better one would be the one which stays on the ear rather than goes inside the ear, because the sound pressure level is low when it rests outside the ear rather than it goes inside the ear. And then we follow a rule called a 60-60-60, 3 times 60. So 60 minutes continuously you can use your devices, whether those are headsets, earbuds. The ones which wire is better than the Bluetooth one. They tend to cause less sensorineural or high frequency hearing loss. You can use continuously for 60 minutes, but after 60 seconds, you take a break of 60 seconds minimum. Not only it helps to recover the ear, but sometimes if you're using the device, your earbuds, which are going inside the ear, they tend to cause irritation of the ear canal skin and causing ear infection. So you get a breather from that. Also, the last part of the 60-60 is you don't keep the device volume for more than 60% of its range. So whether you use it, be it a laptop or a mobile, so you follow the 60-60 rule. And I don't think then you should have this hearing issue related to using excessively any device.
Sorry, what was the last thing which you said? You don't keep it to the volume to
60% of the range of the device volume. So you don't keep it excessively high. Like teenagers, they like to hear music with high volumes, so which is very detrimental for hearing. So even Even the mobiles give you a warning, you have a flash on your screen, the volume is too high. So the device volume should not be more than 60% of its full range.
Right. Thank you. This is very valuable information as well. This is a question which you answered in a sense with on tinnitus. This is by Mr. Chandrakant Behal again, who is age 76. He says, why does the tinkling noise comes in both the ears? This is persisting for many years.
Yeah, so there are other causes of tinnitus also apart from age-related hearing loss or presbyacusis. So one needs to investigate that. So if he is having any other associated symptoms, like a Meniere's disease patient who has a vertigo issue will not only have hearing loss, but he will have tinnitus also. Similarly, if a patient is taking ototoxic drugs, so then he might be having this tinnitus which is there. So the first and the foremost investigation one should undergo after an ENT examination is an audiometry test. If the graph confirms there is degeneration of the nerve by the typical pattern of the audiometry report, then depending upon the hearing loss and depending upon the cause of the tinnitus, appropriate treatment will be advised. But most of the times, the tinnitus, like senile deafness, is irreversible, permanent, and it can be really disabling.
Thank you, Doctor. We're nearing 6 o'clock, so I'm going to ask just 2 more questions, and then I'll going to request you to still look at some of the questions that we've received, and if you can respond to them later. And I think we need to have another session with you soon. There's a question from Mr. Gurdeep Straw. He's yet again one of our regular readers. Why is there dryness in the throat? He is male, 65.
Yeah, so there are multiple reasons, common reasons for dryness of the throat. The first and the foremost is if your breathing is not happening the normal way, if you don't have nasal breathing, where the nose is supposed to filter and humidify air, and then it is supposed to reach your lungs. So this we see commonly when patients undergo nose surgery. They are breathing through your mouth and they develop dryness of the throat. So one should find out if there is any blockage in the nose which is obstructing the typical normal physiological nasal breathing. Second would be dryness of the mouth related to decreased salivary production. So with aging, the salivary production also tends to diminish, and then that can be. Certain diseases, certain medications also can cause dryness of the throat. So these are some of the common situations where there can be dryness of the throat. And if your water intake itself is inadequate, dryness of the throat might be the first pointer that enough hydration is not happening.
Thank you. Doctor, you had mentioned that one needs to do annual checkups for the audiometry tests. Now, there's a question from Mr. Naveen Chandra Shetty. He says, are the usual audiometry tests that are conducted in the senior citizen medical test packages, which are offered with by diagnostic labs and many hospitals, are they good indicators?
So the only thing needs to be seen is if the ambient sounds are not high during testing, then those health packages audiometry tests should suffice. But I have seen that not most of the diagnostic centers are well equipped with a proper sound treated or what we call as a soundproof room. So you might get erroneous results. And also, since it's a subjective test where the participation of the patient is equally important, if the responses are not accurate, then there might be an error in the report.
Right. Doctor, we'll take one more question from Meenal Bajaj, who says she has eye pressure and pain all around her cheek, eyebrow, temples, so can't watch TV or video call. Kindly say why.
So a couple of things come to my mind immediately after hearing such typical history. A is sinusitis and second is migraine. So if she has typical history of colds and the pain is associated during the active episode of cold, then probably it will fall in the category of sinusitis. But no, if she has more of headache or, when she's stressed or anxious and this pain comes up, then it will fall more in the migraine variety.
Doctor, we still have several questions that are there, perhaps around 20 questions that have not been answered. But
sorry, I overshot the time in my presentation.
Okay. I'm going to ask you to come once again to our for our health session, because you've seen the kind of questions that have come in, and these are all genuine, and almost all of them are senior citizens. So, and these questions.
So maybe we can do a part 2 where the presentation is already there, so we can just take the questions directly in the next session.
That's right. That's right. We will. I'll take you up on that. But thank you very much, Dr. Doiphode, for your time. Excellent presentation and excellent session that we had. I must tell you that this was a special demand that we had from our regulars here, and some people who came in last time. They said that we want a session on ENT, so we have addressed that. I must thank the folks at Nanavati Hospital who have helped facilitate this session. So thank you very much again, Dr. Doiphode, for this session and for speaking to our readers and attendees here. We will be back once again next Saturday with another session of Health Live at Seniors Today. We are going to have Dr. Prasanna Shah, who will be addressing us next week, and he is going to be speaking about endoscopy and colonoscopy. This is next Saturday, that is September 4th at 5 p.m. So please be there. And once again, Dr. Doiphode, thank you for your time. It is 1.5 hours valuable time of yours on a Saturday evening. And to all of you here, thank you very much. And we'll meet once again next week.
Thank you. Thank you, Pradhimanji, for having me over.
Thank you very much.
Thanks.